Dear friends, it's been 9 Respinars over the last 2 months. We have discussed various topics involving nearly about 40 panelists, more than dozen of experts and moderators all across India, and with wonderful inputs, insights and learnings. We continue our journey. I thank you all for joining in and also request you to keep tuned and keep joining and keep enjoying this Respinars and be a part of this Respinar by being not only as a faculty but also as a delegate in each and every episode.
Good evening, everyone. Good evening, everyone. On behalf of ICS, I would like to welcome for this another Respinar today. And this is last in the series of treatable traits of different respiratory diseases. Today we have a very dynamic moderator, Dr. Pratibha, and we have our lead expert, Dr. Zia Hashim from SGPGI, and we have a whole galaxy of our young panelists and a mix of people who will be guiding us through this Respinar. So I'm sorry. So before I hand it over to Dr. Pratibha to moderate the session and carry on the discussion on the treatable traits in obstructive sleep apnea, I would like to welcome our knowledge partner. And I want to thank our knowledge partner, Glenmark Pharmaceutical, for providing us this opportunity and helping us in carrying out and dissemination of the knowledge about the respiratory disease. Thank you so much. And over to you, Dr. Pratibha.
Thanks, Dr. Richa. Thanks, Dr. Richa and Dr. Deepak Talwar for kind of, conceptualizing this and organizing this. This has been, I think, a very successful kind of an idea to do the treatable traits in different, diseases in respiratory medicine. And though they have, as Dr. Richa said, it's the last one, but it's not the least one. And I'm very, very kind of, it's good that at least they could, include sleep medicine in this. So the topic for today is treatable traits in obstructive sleep apnea, and we have with us the lead expert, Dr. Zia Hashim, and he's additional professor from SGPGI Lucknow. Dr. Sorin Bhunia, additional professor from AIIMS Bhubaneswar, and the other panelist we have is Dr. Sarkar, who is a very senior specialist from Ranchi. Dr. Khushbu Saxena, consultant pulmonary consultant at Apollo Sage Hospital, Bhopal, and Dr. Yuvrajan from Pondicherry. He's professor and head of the respiratory medicine in the Medical College, Pondicherry. So welcome you all, the lead experts and my panelist. So seems like it will be an interesting kind of a discussion we'll go through. To begin with, let me just share my screen and then we can start from there. So when we talk about OSA, and when I say we are kind of thankful and grateful, at least sleep medicine, OSA would get in the treatable traits, because where we are in still very nascent stage of sleep medicine. It's still kind of an ignored an area. And when we talk about OSA, of course, if we just have to look at the enormity of the disease, in India itself, what we are suspecting is 70 million of people may have OSA, but hardly, it's like more than 80% are still not diagnosed. So we are still there, we are not able to diagnose OSA. But this is again, I think, different countries, and we are at different stages of evolution where the diagnosis and treatment of OSA is concerned. But again, as we understand that this disease is no longer homogeneous, and it's a very heterogeneous disease which has so many underlying causative factors and risk factors and pathogenesis. So we are understanding that just the AHI, the metric that we use, apnea hypopnea index, and sleepiness, is no longer sufficient to kind of give or the right treatment to the patients. So as we move towards the era of precision medicine, it is almost inevitable that we try to expand our understanding of the disease, and then we are able to provide better options to our patients. So with this, I'll like to begin with Dr. Zia. So, Dr. Zia, where do you think we are in our journey of, in the treatable traits of OSA? Because treatable traits are something akin to phenotyping. So, where do you think we are? Have we been able to categorize OSA into very clinically relevant phenotypes? So,
I'm
we'd
actually,
like to know your
yes,
opinion
ma'am.
on that.
Thank you, ma'am, for initiating the discussion with me. That we know that with every disease we have certain different manifestations. Like in OSA, we know it very well that some uh, different, like even some thin people will have a very high AHI even at a younger age, and some very floppy and obese patient will have a normal. They will not have any complaints, and their fat is very well adjusted. And especially, we are very well aware that there is a difference between the male and female OSA. So that's a very well known phenotype which we are knowing from the very beginning, that we have been working. Like we know that female hormones, they basically help females out of OSA, and after menopause, the difference that we definitely know. But there are different other phenotypes, like which are usually based on the various craniofacial structures and distribution of the fat. So we know that there are different phenotypes from the beginning, but we are not able to actually offer them a particular type of treatment, because we know that we don't have many options regarding this, because theoretically we have different treatments. So I would like to hear from other experts that how they think about it, and
Yeah.
what can be best be offered in regarding these traits.
Yeah. So yeah, I think this is very rightly put, Dr. Zia. I think it's like a journey of the disease, like from where we start, and as our understanding develop, and we understand that there's a heterogeneous nature to the disease, and this is very, I think, very akin. Like if we are pulmonologist, we know that how it goes with COPD and asthma. That is how our journey has been. So we have still not reached in OSA at the level of endotype, which is somewhere which is our ultimate aim, because that is where we'll be able to really kind of provide very targeted kind of therapies. But in the absence of that, what we are trying to do is to just to kind of create smaller homogeneous groups, which we call as phenotypes, which can be based on various factors like symptoms or presentations or on the physiology or on the gender. So just moving ahead on this, I'll just give you a little bit of, the clinical kind of, an idea behind it. So this is like, a person who is 39-year-old male with the high BMI of 38, and he was being treated for depression, but was not getting the right kind of, effects even after being on antidepressants. He came to the hospital as a post-pneumonia follow-up, and he had complaint of EDS. So for him, when the polysomnography was done, the AHI came to 27 per hour, which was again a moderate one, and there was sleep fragmentation. So this patient was put on treatment, and of course he benefited from that. And to the extent that the wife was saying, "Oh my God, what has happened to my husband now? He's almost gone to the maniac side, right?" Because that is the benefit of he received with the PAP therapy. So this is a male with a high BMI and with excessive daytime sleepiness. And now this is another presentation, and which was like a nurse who is 28 years old, and then this patient primary complaint was like not able to sleep well and difficulty sleeping, and somewhere we could label it as insomnia. But when the polysomnography was done, the AHI was 7, and again there was sleep fragmentation. And this patient also responded very well to CPAP. So somewhere now, if we see there is so much of the way the genders, like if we just look at the gender, the presentations are different. The BMI even is not kind of deciding factor. So Khushbu, like that is how our understanding is there. Do you think the race or the age or the ethnicity is having implications the way the OSA present, and can we kind of have we been able to create some really clinically kind of acceptable phenotypes in this? Can you please share your ideas on this?
Hi everybody, and Pretty much well said, ma'am. It's not a homogeneous disease anymore. It has various it depends on varied pathophysiology and different pathological features and different presentations amongst the different groups. So there are definitely phenotypes. I would want to share my screen.
Shall I stop sharing something? Does that need?
Ma'am, you need to stop sharing your screen, then she can share.
Okay.
So, of course, as well said, ma'am, is my screen visible to everybody?
Yeah,
Yes,
it is.
Yeah.
you can make it
Yes, sir.
on
I
the
will start. So,
Just one before. Okay, so just in the this thing, Khushbu, I think I will specifically want from you is the phenotypes which are based more on the symptoms and the demographics. Like
yes.
because rest of the things we'll be discussing later also, like pathophysiology and the physiology.
Yeah. So I'll skip on the endotype part, ma'am, and I would just come up to the mostly I would go and emphasize on the cluster analysis that has come. Recently, this concept is emerging very. I mean, logically, it is emerging, and today I will be discussing about patient symptoms and demographic based features and phenotypes of patients. So, so the cluster analysis, mainly patient symptoms have been predominantly given a lot of importance when there was when the concept of cluster analysis evolved, and the study population usually has included more than AHI more than 15, and the symptoms which have been concentrated mostly are sleepiness, insomnia, nighttime disturbances, upper airway symptoms like snoring and other related like morning headaches. So what have we have studied during our post graduation and MBBS days is always like a patient who is obese, who is elderly, and who snores very loud. Only such patients usually are suspected to have obstructive sleep apnea. But as Yasser has already mentioned that it is not always true. A lean person can also have these things, and an obese patient might not be having symptoms that way, but definitely they are having disease and they are getting benefited. So as per the symptoms, disturbed sleep, minimally symptomatic disease, excessive sleepy and moderately sleepy, these have been categorized, and to know about as a fact that the heart failure and cardiovascular risk and hypertension has emerged very likely in such patients, and also about the systemic hypertension. And symptoms and these symptoms did not track well with the AHI and Epworth sleepiness score, which we usually take into account while screening our patients to have these issues. They capture only a part of the spectrum. And as you have already told us that CPAP treatment and quality of life is different according to the symptom cluster, and they all are usually getting benefited out of CPAP. As far as we are taking about the demographics, so first patient which you have discussed is fitting very well into the male obese with excessive daytime sleepiness and low on comorbidities, are having a high AHI, and these patients are very prone to have this excessive daytime sleepiness and symptoms like drowsy driving, and the incidence of CVD, this cardiovascular risk, are very high, and they are most benefited out of CPAP. And the second category, which are older male obese, they would take naps, snoring disturbs the partner, and the AHI again would be high, but the CPAP adherence would be poor. The high and on the contrary, to young males, the incidence of CVD is little lesser. However, about type A, we can say these symptoms have made the presentation earlier, so probably they are not presenting with the comorbidities, well as the older comorbid people probably had disease for the longer time and they haven't presented. Going on to the subtype C, these are females rather than having excessive daytime sleepiness, they would present like with the complaints of insomnias, and they are the least benefited patients. So rather than just offering them CPAP, CBTI, just like cognitive behavioral therapy along with the CPAP should be targeted. And the youngest upper airway predominant symptoms like snoring, a sudden awakening, and disturbed sleep, they also have very low CPAP adherence and unknown risk factor for cardiovascular diseases. So,
Yeah. Thank you. I think that's pretty much in, you have set the tone very well. And I think if we just look at this slide and we just kind of try to kind of understand this, is like just putting our knowledge into this, creating clusters will help us understand that when we are doing polysomnography for a patient, it is just not that we prescribe a treatment based on the AHI. So if we just like to put in a little of an effort to which cluster this patient belongs, we may be able to provide better treatment and better alternative. It's just not the PAP. It's not that one size fits all. So like for, again, a subtype which of a female which has insomnia, then just the CPAP may not help. And along with the CPAP, if we kind of offer the CBT to this patient, that may really be useful for this patient. So it's
may
like
I just
one thing I
a
would like
quick
to add,
short
Yeah.
description of a patient that reminds me, ma'am, we had a patient like around 45-year-old female, obese, and she had come with the complaint that I have never slept ever in last 2 years. And then when we discussed this with the family, they would tell, no, she is pretty much sleeping, but I don't know why she's always complaining about it. And probably that was the presentation of paradoxical insomnia,
Yeah.
and we had made the patient. So she had visited a few consultants and few specialties before, where she had been prescribed clonazepam and sedatives, which was further worsening her OSA probably. So I mean, this cluster has to have a separate space in the diagnosis. It has to get highlighted even more.
Right. Yes,
Yeah,
Dr. Zia, what you were
yeah,
saying.
yeah. I was telling the same point that often actually females are treated more like anxiety, and because their symptoms are non-specific, so they fall into that category, just ghabrahat and all that. Na?
Yeah.
So the diagnosis is often missed in females, and the females tend to underestimate their symptoms. That they will have like they're not very sure about what they are feeling, so they will just say that they are not feeling well, there is ghabrat, there is anxiety, so they usually go to psychiatrist first, like Khushbu said, very well said.
Yes.
and
Yeah.
uh, and they
So
think
yeah,
that obesity is
so
just a
that
part of
is
their lifestyle.
yeah. So that's why again sleep medicine is a multi-specialty kind of a thing. Like, this needs a lot of cross-referencing amongst, the medical fraternity itself. So the patients have to be picked from, various, specialties basically. So if you allow me, Khushbu, I can share the screen again.
Sure, ma'am, please.
Khushbu summarized it very well. I think
Yeah.
this whole seminar is summarized into this slide.
Yeah. That's true. It's been a very
Thank you
this
so much,
slide
ma'am. Thank you.
specifically is very good. This one is really kind of helping us
Yes.
understand.
I have stopped sharing my screen, ma'am.
Okay. Okay. So I think next so this was like, again, I will say that again, reiterating that phenotype is almost equivalent to treatable traits. And what we just discussed was like some treatable traits which are based on the gender and the age and the, again, various demographics. So now there are like, various ways we can phenotype, the patients of OSA. And the other way is like, on the polysomnographic traits. And when we talk about that, the one thing that, somewhere we have been able to do well is this is positional, predominant, supine predominant OSA, which will be positional OSA. So my question is to Dr. Soren. So Dr. Soren, what is our understanding on POSA, which is positional OSA? Does identifying POSA really help us in our approach to our treatment? It just changes anything for us? Dr. Soren?
Good evening, everyone, and thank you, Dr. Pratibha. I think a very important trait you have raised is POSA, otherwise known as the position-dependent OSA. I think this is mostly overlooked. Most of the time, it is overlooked. So, defining POSA is whenever the obstructive sleep apnea is present only during supine position. At that time, we term it as POSA, and even some authors have coined another term called e-POSA, means when it's exclusively in supine position. So this POSA is the incidence is around 40 to 60% even. It has been found in the literature, and that exclusive POSA is found in around up to 20% of patients even. So now let's first understand why this supine dependent OSA takes place. What is the mechanism behind it? So usually when a person lies supine during sleep, so it has been found out. Some studies they have reported, they have done sleep. I mean the endoscopy during sleep. So they have found out that there is increased collapsibility of the upper airways, the base of the tongue, the lateral pharyngeal walls, the epiglottis, the soft palate. So there is increased collapsibility of these upper airways, and to add to that, the gravity dependent falling of the tongue. So these all contribute to increase the compromise of the in the caliber of the upper airways, and they lead to the increased incidence of OSA during supine position. So as you have summed it up in your slide, the profile of the patient in POSA, usually the younger patients who have usually normal, or I think the BMI is less as compared to non-POSA patients, and then usually these patients tend to have less comorbidities, and the AHI is usually less in such patients. So when we come across such position dependent OSA during polysomnography, so we have to be very careful. We should wait till the REM sleep comes, so that it doesn't get underestimated, the amount of the events that are taking place. And then usually the treatment part, usually such patients tend to have less severe AHI. The AHI is either mild or mild to moderate. So in that case, the first line of treatment that we should plan is the positional therapy. The previously, I think the conventional, that the tennis ball method, which was there, the ball used to be stitched to the on the back of the shirt, so that whenever the patient tends to fall on the supine position, they will feel that irritation, and they will just go on their sides. So the compliance with this tennis ball was very less. And so now, because of this advanced technology, we have come up with many new gadgets. The vibratory gadgets have come up, which are quite advanced, and they are usually worn around the chest or neck, where they sense the supine position. As soon as the patient it detects a supine position, it starts vibrating till the patient goes back to on the sides. So they are found to be they are more sensitive, and they are patients are found to be more compliant with such devices. And the one extra advantage of such devices is that even they can record, and they can monitor the compliance of the device, such devices in such patients. And secondly, the CPAP has always been the gold standard for treatment in OSA. So even CPAP can be tried, but again, the compliance is not much, because of the mild to moderate severity of OSA in such category of patients. But one important thing is that in such group of patients, an trial of auto CPAP can be given. Usually such patients given history of, maybe if we take a detailed history, then we can, they give a history of alcohol intake usually. So they tend to have more OSA in supine position. So in such cases, even an auto CPAP can help in such patients. And another very important aspect of management in such patients is that even we should closely monitor such patients, because this mild to moderate may progress to severe in such cases, so that the approach to treatment will change from the positional therapy to CPAP. So there is a role of closely monitoring such patients in POSA. So
Yeah, thank you, Dr. Soren. Very, very well summarized. I think you have covered all the points. So the only thing we will like to stress again, for the audience is that yes, POSA is an entity. This is something which is very well defined, and it's again something. It's something which can be easily picked just on the polysomnography. And in these patients, like the AHI in supine is like more than 50% than AHI in lateral. And it is due to this underlying anatomical factors, something like they have a smaller lateral wall and the facial height is low and they have a shorter neck size. So all these very characteristic anatomical factors also lead to the patients having positional OSA. Dr. Zia, if you would like to add anything to this.
Yes, but what I feel that regarding these traits is that so commonly things like overlap syndromes with asthma and COPD, they also form a different type of, and they are very common.
Yeah.
Like most of the patients, they are obese and they will be having some asthma.
Mhm.
And then their asthma becomes very intractable, and their OSA also, we give them steroids, and then the obesity also increases. Then that form also is a very important group.
Very important.
Yes, because
Definitely.
most of them either will be having COPD or asthma with this, and sometimes if they are having CO2 retention, OHS type of trait. Then these are also very common types of things which we should look at, like in this classification of traits, overlap syndromes, and with OHS overlap, and because they will have a slightly different, because if you control their basic disease, give them very good inhalers, and like in one patient we had to use omalizumab, and then the OSC got better because these are interconnected, because if you control asthma very well, then
definitely. Yeah. So some things, like when we are not getting the right kind of results, we have to look into, like this patient may not be
I would want to add one more point if you allow me.
Yeah. Please go ahead.
Definitely overlap is there for this thing. We found a lot of OSA cases in those patients severe asthma. Last year, I gave thesis for one of my PG student. So that was the thing. Well-controlled asthma definitely have a good control over mild.
Yeah.
So, ma'am, actually, even when you titrate patients for adequate pressures, when you are doing manual titration, many a times patients do not get settled with the CPAP alone. You might have to, go for a higher advanced mode like a BiPAP. So, if you position the patient a little bit lateral, you have the pressure, the titration pressure, adequate pressure comes down from BiPAP to CPAP. So that way is also, it cut the cost of patient's device which they are supposed to have. So
again,
the combination works sometimes very well.
But then I'll tell you, like, again, what the studies which shows, and which we have very limited studies on these things. So even the patients with POSA, they have not really been very happy with the the other therapies. So again, when you are saying that we cannot do that, rather when we titrate to that patient to the supine level, because the patient is not going to be in lying, sleeping in one position all the time. And you are saying that we can add a positional kind of a device along with a CPAP, which actually, it's a good proposition, but maybe difficult, because patient anyways is not very happy with the vibrational devices, because anyways it's irritating. And so again, for the patients with POSA, the more acceptance is for the auto CPAP rather than the devices, positional devices. And auto CPAP again, because the the requirement of the pressure is changing when the patient is supine and the lateral. So that is why they are taking in the auto CPAP better than the fixed CPAP. But yes, it's a good wishful thinking, I will say.
Madam, can I ask a question?
Sir, yes. The next question is for you, sir. So we have to ask you a question first. So may I ask you a question, sir?
Yes, of course.
So the question is for you. So we are moving to another kind of a trait, which is, I will say, again, again, as we understand the beauty of sleep, and that sleep is not a point phenomenon, it is happening in stages. And then, of course, it's non-REM and REM, and non-REM is a further in stage 1, 2, 3. So we know our understanding is very clear that how REM sleep, the physiology is different than the non-REM. So when we talk about the REM AHI, so do you agree that it is itself a different entity now? Like we, rather than looking at an overall AHI, we should be also looking at the REM AHI. And if REM AHI is like more than 15, but the overall AHI is less than 5, do you think this patient may warrant a treatment?
Yes. So it might be a patient of REM-related OSA, and you want to discuss on the REM-related OSA or importance of REM-related OSA. So you are giving a condition where the overall AHI is less than 5, but REM OSA is more than 15. So at first I want to know, madam, what is the actual REM sleep time in this case? I think that must be an important factor here.
Okay.
REM sleep time should be always noted whenever we come across this sort of patient. Suppose the patient has REM sleep of 6 minutes only. And during this 6 minute period, patient had 2 obstructive events.
Yeah.
So then the calculation comes to be about 20 REM
Yeah.
But 6 minute REM might not be so clinically significant in that case. Or a patient is in REM sleep of only 6 minutes, and during this 6 minute patient has 3 episodes of obstructive sleep apnea or obstructive event. Then the REM calculation REM OSA will be 30.
Yeah.
So only looking at the numerical value, REM OSA is not so significant. I think there must be mention of the REM sleep. And I think at least 30 minutes of REM sleep is important for producing any pathophysiological event. So whenever this sort of reports comes here, we must look for the REM sleep duration, which is a very important factor in this case.
Yes.
Again, another point in this, I want to say here that the REM OSA again is said to be present when the REM sleep, AHI REM is double or more than double of the non-REM sleep. So that is the REM OSA by definition, which is accepted now. And the overall AHI is more than 5. So in this situation, and if the non-REM AHI is less than 5, then it is called isolated REM OSA. If the non-REM AHI is more than 5, then it is predominant OSA. So again, like OSA, whether it is predominant supine or isolated supine, the same criteria is also here, more than 2. So REM OSA, the REM AHI double the non-REM AHI. And if non-REM AHI is less than 5, then it is isolated REM OSA that has a much more clinically important significance and is REM predominant OSA. Now, I think if we consider the importance of REM OSA, which you want to know, so there are certain pathophysiological important consideration. As you said, so in comparison to non-OSA, the REM obstructive events have longer duration and greater decrease in the oxygen desaturation or greater oxygen desaturation. And that's why, because of the profound atonia of the muscles as well as decreased sensitivity of the chemoreceptors. So there will be longer duration of obstructive event and greater oxygen desaturation. That is one.
Yeah.
And another thing is during REM OSA, there is sympathetic hyperactivity and cardiovascular instability. There is increase in heart rate, increase in blood pressure, and also increase in the cardiovascular demand for oxygen. And there is an increased chance of ischemic events during this REM OSA period. So these are pathophysiological consequences. So overall, REM OSA is definitely a high risk for the development of hypertension and cardiovascular complications. And there are certain 2 or 3 clinically important factors also. REM OSA, usually they are young, usually in the women, and they usually present with insomnia or depression-like symptoms. So excessive daytime sleepiness is absent in these cases. So mostly they present with insomnia or depression-like symptoms. And naturally, here the chance of diagnosis, delayed diagnosis and delayed therapy in these cases. And secondly, the most of the cases in the community now we use home sleep apnea test for the diagnosis of OSA. The mostly used nowadays in most of the parts of the country, I think, and occurs in my places also. So, but home sleep apnea test will miss the diagnosis of REM OSA. We must be remembered that. So again, we titrate with auto CPAP, and REM OSA are very poorly titrated with auto CPAP. So diagnosing OSA with home sleep level 3 and auto titration with APAP is again negative points for the REM OSA. And thirdly, regarding treatment part, we are prescribing CPAP, and we consider adherence of CPAP for at least 4 hours for more than 70% of the nights. So 4 hours from the night, that means the REM OSA are predominant in the early hours of the morning or later period of the sleep. So REM OSA will not be treated properly if the patient uses only 3 or 4 hours of CPAP after light off. So there is a diagnostic problem because of the presentation, clinical presence. There is a diagnostic problem with the home sleep apnea test or level 3. And there is again a treatment problem. The patients are left untreated if the patient uses only 4 hours of CPAP. So these are certain clinically important things I want to highlight here. Now, in your case, there is overall AHI less than 5, but REM OSA is more than 15. So according to the criteria, the patient is no sleep apnea, actually no OSA.
Yeah.
So the question is whether to treat or not.
Yeah.
So in my opinion, considering the risk of development of hypertension and cardiovascular comorbidity in REM OSA, considering this danger side, we must treat this patient with REM OSA. And we should advise use of CPAP more than 6 hours or full night to cover the early hours of the morning REM OSA. And still, they show very poor CPAP adherence. These patients of insomnia or depressions, and they show very poor CPAP adherence. And then what to do? So here also, according to the phenotyping criteria, it has been found that the REM OSA patient has low arousal threshold. Low arousal threshold is the predominant phenotyping, underlying phenotypes in these patients, and they have low CPAP tolerance. And then question comes whether the insomnia and low arousal threshold can be treated with treatment drugs like S-Jopitol. And that will help to raise the arousal threshold and will increase the adherence for CPAP. So patient has to advise a CPAP full night use, and we can add a low dose S-Jopitol, 3 milligram per day or like that. And we must advise to use the CPAP throughout the day. So this should be.
Thank you. Thank you, sir. It has been I think you have raised the very, very, very valid, very, very relevant points. So just like if I have to give a take home message in this is like, as of now, when we're doing our polysomnographies, just don't look at the overall AHI because REM AHI is there in the polysomnography report.
Definitely.
So for now, if we just sensitize ourselves to start looking at the REM AHI, that will be helpful for us. And of course, in the long run, you have to look into a lot of details as Dr. Sarkar has mentioned. So this is again a trait that needs to be focused at, and that should be treated, the REM AHI or the REM OSA. So we'll just, in the benefit of time, we'll just have to move forward a little quickly, and we'll come to our next entity, and the question is for Dr. Yugarajan. So till now we have covered the phenotypes which are based on the demographic and the symptoms and anatomy. And now I would like you to kind of throw light on this physiological phenotypes. It's again a very kind of a framework approach where we are trying to kind of measure simultaneously various physiological traits, and we call it as PALM, which is again a very nice kind of so I just want you to kind of elaborate on it so that for the benefit of our audience they understand. So this can be the non-anatomical treatable traits in OS that we have just very recently kind of figured out. So over to you, Dr. Yuvrajin.
Yeah, madam. Good evening, one and all. Actually, this is a very nice point that is raised now. In addition to the anatomical factors, we need to see the non-anatomical factors also. We need to categorize this patient for the effective management. In addition to CPAP, we have to think of other things like. So usually there are 4 issues we face in this group of patients. One is the anatomical compromise that what we already discussed. And second is inadequate response to the response of upper airway dilator muscles. That usually there will be minimum change in the EMG to respond to the negative pharyngeal pressure, and these patients also have a low respiratory arousal threshold. Very, very important. This low respiratory arousal threshold is that the patient have a premature waking up, this thing, in response to the airway narrowing. That should not happen. And most important thing is, oversensitive or hypersensitive ventilatory, system. That is the loop gain, what we call as a loop gain. So that is one of the bad things that is happening in this group of patients, in addition to the anatomical factors. So as he rightly pointed out that the PALM scale, it's one of the, recently introduced scale. That's a very good scale. P stands for the critical pressure. It is actually a gold standard parameter that you need to measure. That is the pressure that is required to open the collapsible airway. So normally upper airway tends to collapse, and these patients have a more collapsible airways, and this pressure is named as a very critical pressure, so that this pressure is needed to open that collapsible airways. That needs to be measured in this group of patients, and based on that we have different categories and or there based on the critical pressure, and we can measure this critical pressure with modified CPAP. Basically in the research sleep labs it is there. And the thing is, all these things actually it needs a lot of cumbersome devices and a lot of training for measuring that, and you need a very good sleep lab along with all the mathematical data to extract the data to derive all these equations. That actually needs some more time and need more studies on that. P stands for the critical pressure that already we discussed, and then A stands for arousal threshold. Already we discussed this. Most of the patients will have a low arousal threshold. That is actually adds a fuel to the fire in this group of patients. And the third one, L stands for the loop gain. That already I discussed. Loop gain is nothing but it's another engineering term. Actually, it's a term that is used by engineer this thing and all. Basically, loop gain is that your ventilator system responds all to your negative feedback. Okay, so in this group of patients, they have excessive or oversensitive, ventilatory system. That in addition to the one response, they'll have a 5 times response, and that is actually disturbs their ventilatory cycle, and then that will aggravate the issue. And then for the M stands for the muscle recovery. So based on this scale, actually, we have once again the grouping. We will group the patient into 3 categories. That is PALM 1, 2, and 3. The PALM 1 group of patients, usually they have a very higher critical critical pressure, that is more than 2.5 centimeter of water. And these patients are grouped under major anatomical issue. Definitely these patients have, since they have higher pressure, we need to give CPAP and other options for this group of patients. And PALM 2 is the thing, they have a moderate anatomical issue. Along with that, once again, we can classify this PALM 2 into 2 categories. One is A and B. So A, they have moderate anatomical issue, and they don't have non-anatomical issue. That what we discussed. Other than anatomical issue, they don't have the non-anatomical, that is loop gain, RPS, all these things. They don't have that actually. So in this group of patients, once again, we can opt for therapy based on this actually, CPAP along with mandibular advanced splints, along with upper airway surgery, provided they're feasible. And the PALM scale 2B, that is 2A, 2B, 2A. No non-anatomical issue, but 2B have a non-anatomical issue. So usually they have a permutation combination of 1 or 2 non-anatomical issue that needs to be addressed along with the regular treatment. So usually the mandibular advancement splints, oxygen, and we can change the posture, and we can give hypoglossal nerve stimulation. I don't think it is available in India. So these are the things can be tried along with the regular therapies. And this PALM scale 3, which is actually the critical pressure is far less than minus 2.5. So these group of patients, I think we can just, alter the non-anatomical factors with 2 or 3 permutation combination without CPAP. They do much better with this group. So that's why we need to see all these parameters nicely to, tailor to give a tailored approach to our patient instead of sticking on to only CPAP.
Yeah. Thank you, Dr. Yuvrajin. Again, a very kind of, you have explained the things very well. So again, just for the audience, I would like to say for our, PGs, like these traits, the physiological traits we are trying to measure, but again, the complexity of the technology and the expertise is very high. So it's not that they are available as such for us at this point. But again, as our, the AI, artificial intelligence comes in and the logarithms, they get better, we will be able to kind of make it out. So like this is a polysomnography and we will be able to figure out the loop gain of this patient from the polysomnographic logarithms itself. Even the arousal threshold, again, that can also be measured from the polysomnography. So these things which now may seem like, they are not in practice or we may not use it, but in the coming times, we are very near to it. So once, the logarithms get better and we are able to get or extract this information from the existing technology, we'll be able to address it also. And again, he has said that PALM, Dr. Yuvarajan is saying that basically we're looking at the 3 physiological parameters, which is your arousal threshold and your, the responsiveness of your upper airways to any stimuli, and also the loop gain, which is basically the instability of your, ventilatory system. So I think we will just cover the non-PAP, options that we can give to these patients. Dr. Yuvarajan, you can just speak on this also, like depending upon, you have already spoken, but depending upon the predominant trait. So largely, these are the 3 kind of things we can offer to the patients.
Yes, madam. Like in addition to other things, like basically we start from the lifestyle modifications. We do give a positional therapy, all the things we have discussed. So we can use some drugs. Actually, we as you projected a slide on some of the drugs that have been approved by European Medical Agency and also by FDA. That is automexetin. That is a non-adrenergic reuptake inhibitors. So actually, this drugs have been tried and have been very well studied that it reduces the AHI, as you rightly pointed out that. But actually, it has not been approved in all the countries. Very few, societies only approved these drugs. In addition to that, like those patients who have a low threshold, we can use this trazodone or Espilone, and some other benzodiazepines also can be used with partial success. So actually, based on the studies, based on the literature, these drugs actually have not been given 100% success. So it is actually they're not very sure that they will work or not, but definitely these drugs plays a major role. And those patients who got a high loop gain, definitely carbonic acid inhibitor and oxygen, acetazolamide. There are some other drugs all been approved, so that can all be used. And in addition to that, we have surgeries, we have splints actually, oral appliances, very, very important. So dental sleep medicine is a separate specialty. I have 2-3 patients on follow-up with all the splints actually. That was made in France actually. That was very nice. Like they have the splint and then with a titration, they have screws in that. So we can titrate also in future. So that is there. Those patients who got a mild to moderate OSA and those patients who got very compliant with your CPAP therapy, and those patients who got a good dental, good exposure to central sleep medicine, because they need to prepare this splint very nicely based on their anatomy.
So yeah, Professor Yuvraj, so I will tell you that this is, we are doing this is happening in India also, the mandibular advancement devices. So recently I was in Pune, in Nagpur, and there was this dentist who was doing this entire work, and it's again very well received, very well received. Dr. Zia, anything you want to comment on the PALM scale or the physiology-based therapeutic approach?
I was answering the questions.
And two more drugs.
So you are answering the questions in the chat.
Yeah,
Right.
because somebody, Dr. Bhumika Patel, she's asked to share. She said that she would like to listen more from Dr. Khushbu on her entire presentation. So I was just typing that Khushbu will share her presentation, and you need not ask her to speak again.
We may have another presentation. We may have another presentation from Dr. Khushbu. Dr. Khushbu, you have for your next question, do you have a presentation or?
Yeah, I do have a presentation.
Yeah, I know.
I'm more comfortable because things should not be missed. It should go the way
your presentation is in demand. So share your presentation with Dr.
Thank you
Bhumika
so
Patel.
much, Dr. Bhumika, and I'll share my presentation with you. And ma'am, actually, I feel our interests are pretty much overlooked. We should do it more often. Having discussing the cases about sleep medicine.
Yeah.
Yes.
So what we should
another
do.
question is second question is do we need to do an exclusive sleep study in lateral position to see if AHI significantly comes to down at the positional therapy? I think Dr. Surin.
Dr. Soren? Dr. Soren is there.
Hello. Yes, I don't think we need to do a study with exclusive lateral position. So whenever the positional therapy is adopted, I think the patient gets relief from the symptoms that they have been facing. I mean, the daytime sleepiness or lacking concentration, whatever was their symptoms which the patient presented, those will come down. So I don't think we need to do we can't do, in fact, a sleep study with exclusive lateral position. So.
Okay.
Yeah, sir, I would want to add to it that usually patients, they take their comfortable position and only 30 minutes are required to judge on whether the patient is having positional OSA. As per the studies which have been conducted in the past, even a duration of 30 minutes in lateral position may tell you that whether the patient is having positional OSA or not.
Yeah. So totally agree. Yeah.
Another question is on REM OSA. There are a lot of sleep studies, despite of best sleep shows REM very low percentage, and this is just because the marking is not done by the actually it's being not manually done. I think if you do it manually, then you will pick enough REM sleep, because REM, it looks like N1 only. If this problem will be solved if you titrate, if you score your sleep studies by yourself.
Yeah, or maybe there is they are not sleeping. The study is not done for a sufficient time. So as they said, you have to do it for 6 to 8 hours for REM to appear. So yes, yeah. So there are a lot of issues to get that right. Labeling it right to the REM OSA. Yes. But usually, in the split night studies, when the patients, in the split night studies, it's very difficult to get the diagnostic, REM in the diagnostic part. So it comes in the therapeutic part. So if we are suspecting, then we have to do the, complete night study. So, or the 2 night studies. So, right. So let's move on to the next thing. So now on to Dr. Khushbu. So this is again a clinical scenario for you, Khushbu. So this is a 54-year-old man. He's already on 4 drugs for hypertension. He has heart failure also in the OSA with the AHF 20. But he was not able to tolerate CPAP, and then his hypertension is worsening, and even the OSA is worsening. But the CPAP is he feels that the air does not going into his lungs. So this is basically CPAP failure patients who actually need a CPAP. And then because this patient was, this is what his cephalometric measurements look like. And then what was observed was there is a lot of, narrowing at the mandibular area. And then this patient was offered another treatment, which is maxillomandibular advancement surgery. And then just by doing this, we have been able to open up the airways. So the question to you is on the phenotypes based on the cephalometric measurements. So how are we kind of incorporating into our clinical practice to really give us some, good or the clinical outcomes, or to get a meaningful clinical outcomes out of that? So
that's
this
right, ma'am. Actually, here we are, it's not always like patient is having OS and we are just subjecting patient for CPAP. We do need to have a look around how the anatomy is, how the facial anatomy. Sometimes getting the anatomy right only will give you a clue whether the patient is going to, tolerate the usual pressures, or he's going to have require a lot, like huge pressures. Sometimes we do have titrated with the pressure requirement of IPAP of like 30. So, it is very intolerable to patient to have these, and screening of an upper airway examination is definitely very important as far as OSA is concerned. So I would again want to share my screen, ma'am.
Right, I will just stop sharing. Just before that, I will just show one slide, and Khushbu, then you can take over, because this is what Dr. Zia was telling us in the beginning. So again, for everyone to understand, it is not that, just this, the airway opening will be narrowed only if it is a high BMI, just because of the facio-anatomical structure. So even like if you just look at this female, which has got a recessive, the mandibular, this is like a chin recession is there, or the mandible is narrow. even in those patients, the cross-sectional area at the back of the tongue. So anything that decreases the cross-sectional area at the back of the tongue will be the causing, factor or the risk factor for causing OSA in that patient. So the patient may be very thin and lean, but the cross-sectional area is less. So this patient can have OSA. And of course, this patient, so we will just look at this patient and say, oh, this patient will have OSA. So I'll just stop sharing here, and Khushbu, you can please connect.
Yeah, sure, ma'am. Thank you. So I'll directly go to the examination part of upper airway. So, of course, we have got to know about endotypes and phenotypes. Let's discuss about a few more things, like expansion of regional fat also plays an important role for.
Can you make it? I think
I have made it full screen, sir. Is it visible well?
Yes. Now
Yeah. So regional fat deposition is believed to, compromise the airway space, whereas visceral abdominal obesity reduces the lung volume and therefore caudal traction on the pharynx, leading to predisposing the person towards OSA. Neck circumference also plays an important role, and we have been doing this and studying this for a very long time. So as you can see, the normal, the first figure, you can see the tongue is placed normally, the airway is patent. You can see the soft palate, normal retropharyngeal, retropalatal space, everything is there. Once you have this excess fat in submental triangle and your tongues get displaced, you can very well see the tongue is pushed towards backwards, and there is diminished intranasal space, retropalatal space, and large soft palate, uvula, everything. Also, you need to examine for the turbinates because there are many times swelling, allergy related issues, and patient might present like upper airway respiratory syndromes, more rarer kind of a picture. So this picture is depicting how there is a reduction in the lung volume and reducing the lung reserves and leading to profound events during sleep study, which you usually observe. The measurements which we are taking are neck circumference, which ideally we should do below the thyroid notch from the occipital space. Then thyromental plane, thyroid notch. We know these landmarks, and we have to measure the angle between the two spaces. Then the shorter thyromental distance also predisposes the patient towards OSA, and cricomental space, which is the line perpendicular to the thyromental distance from the angle of from the
We will have
thyromental
to
angle.
just a little bit hurry up because we are just left with 5 to 6 minutes now, and we have to close. So what we were, you can just summarize it, I think. Khushbu, if you can just summarize it on your own.
Craniofacial factors, because predominantly it's a surgical part. Here, the surgery plays an important role, and the so in the patient with larger soft palate and tongue, surgical interventions such as uvulopalatopharyngeal plasty and tongue volume reduction can be considered. Also, in the retroposition mandibular and genioglottal advancement can be a suitable treatment options for the management of this condition. However, the anteroposterior positioning of maxilla did not play a significant role in the development of OSA, which was pointed out in the previous study. So the surgery might not be as useful as it was pointed out in the previous text. Also, ma'am, you have already discussed about maxillomandibular advancement and expansion. So it creates a lot of room for tongue to stay in the space and provide space. And it is this is the only surgery which is recommended in severe OSA wherein the AHI is higher. All these surgeries usually they are indicated and has shown beneficial in the mild to moderate OSA, which usually patient would not agree for. So this is.
So I think the point here we are trying to again reiterate is that again practice of OSA is a very multidisciplinary approach. And as pulmonologists, when we are looking at patients and then there are certain cases we think that patient is not tolerating the PAP therapy. we should kind of reach out to our colleagues like, the dentist and the ENT people, right? So of course, with the maxillary advanced devices, this is just an option which is other than the PAP therapy. Many patients who are not able to tolerate PAP will be able to tolerate the MAT devices. And similarly, like in the severe patients, the surgery can really help. So it's again, a multidisciplinary approach that we have to take while we are treating patients of OSA.
And very important that we have to make a complete diagnosis. It's very important that clinical diagnosis is very important. Like I was doing a project on acromegaly in OSA, and last year we published a paper on that. And then we did a reverse thing. We started measuring IGF in patients who were coming with OSA. A lot of patients we could see that IGF was higher than the normal. So basically, if we control the level of growth hormone in that patients, and then we referred them to endocrinology, and then their OSA got better with the treatment. So if many patients, they are having subclinical acromegaly. So it is very important that we examine the patient properly, and if there is any comorbidity like asthma, COPD, and OHS, then we should also, because these are treatable things.
They are treatable things, right?
Sir, how frequently are we doing DISE? I mean, do you have access to drug-induced sleep endoscopy to identify more of, surgical cases?
No. Very difficult.
So this is done by ENT people. Like if you want, so most of the ENT doctors who are practicing sleep medicine, they are doing DISE regularly. And again, that really help us to, this is another very important, again, a treatable trait that you have. So if there is a, collapse at any level, that ENT people can take care of. So DISE is being kind of taken care by the ENT.
Definitely. And when the kind of ENT we have at Khushbu must be knowing that not every place ENT people are.
Yeah, may not be, but it's again a very kind of a doable thing. Any ENT surgeon who is interested in sleep related surgeries, they definitely do that.
Like even a dynamic MRI is usually radiologists would just say no, we don't have time to do your MRI for that.
Right. I think Dr. Richa, are we like, what is the timeline for us now, or we can discuss one more thing? Dr. Richa is also not there.
There are certain questions on the chat box, but most of them, most of them have been answered by the speakers, and I think
the role of modafinil, I think they have asked actually.
Modafinil,
that is actually a residual excessive daytime sleepiness. Actually, that's the part we have not discussed. Even after starting a proper CPAP, some patient used to come with a headache and excessive daytime sleepiness. But before switching on these drugs, they need to see the adherence to the CPAP therapy, their compliance. They have whether they have a well-fitted mask, whether the therapy is adequate or not. Other comorbidities like narcolepsy, depression, other things has to be ruled out before putting these drugs actually. These group of patients, like we can try this modafinil or modafinil. Even after instituting a proper CPAP therapy, they complain of headache and excessive daytime sleepiness, we can do that. There are one more new drug has been approved even by FDA also. That is not that is soldrium fetol. It is approved by FDA, especially for excessive daytime sleepiness.
Can I add to that, please?
Please.
Actually, I had one patient where the patient had severe OSA, and on top of that, despite giving CPAP, he was continuing to have the excessive daytime sleepiness. Then we did MSLT test, and then we found that he has got narcolepsy also. So there can be patients with OSA and narcolepsy combined. So in that case, we can give. We added modafinil to that patient on top of CPAP, and then he's doing fine now. So we have to be very careful whenever we find persistence of symptoms despite adequate adherence to CPAP. Then we should look into such associated narcolepsy also.
Yeah, very well answered. Yeah, that's how things are. There's another question, Dr. Sarkar, would you like to answer? This is like on the patients of congestive heart failure with OSA. So what is the right approach? congestive cardiac failure, patients with obesity who have both central and obstructive sleep apnea, what is the best advice? Dr. Sarkar? Sir, you're on mute, sir. Can you unmute yourself?
Yes.
Yeah.
Actually, they poorly tolerate the CPAP in these situations. And particularly, the patient has either BiPAP support or AVAP support or advanced modes of the ventilatory supports can help in this situation.
So another thing I think
should have a chain strokes respiration in these patients, and they feels the trouble with the during the hyperventilation period particularly. So newer mode of ventilatory support, particularly in this cases, helps.
So yeah, so there was like, this is something I'll just little add on this thing because, because when we worked and if you work as a pulmonologist, any center which is very like cardiac center, like I worked in Medanta, there were a lot of central sleep apnea patients that we had seen. So basic kind of, approach stays the same. Like you kind of, if you diagnose that patient as OSA plus central sleep apnea and the patient has cardiac, any congestive cardiac failure. So you first optimize the treatment for the cardiac congestive failure. So you have to optimize the cardiac functioning. That is the first thing. And then so basically you will kind of, use the CPAP for the OSA correction. So then things kind of, take care of this. So ESV is like still not again very much available, and there is still a lot of kind of, there is a lot of kind of issues to be kind of, it's not a very clear indication as yet.
May I add to it, ma'am? The best advice would be please wait for advantage of trial results. I think it would give us clearer indication. It's a huge topic of debate how to manage congestive cardiac failure along with OSA and central sleep apnea. It's a huge topic of debate.
It's a huge topic, but till now CPAP as such is still safe enough rather than any other thing. It's not that these patients need BiPAP. This is not that they need, servo ventilation. At this, whatever evidence we still have.
Yes.
So if we have to play safe, the play safe thing is to optimize the cardiac, underlying cardiac pathology and then use the CPAP to correct the OSA. I think we are running over time, so we can close the session. Dr. Zia, thank you so much for
thank you, ma'am.
really this time. You are bringing out this time.
I think there is one question here.
Yes, sir.
One the doctor asked about the role of polysomnography for identification of the non-OSA, non-anatomical.
Yeah. So I just read because I just covered. I showed the 2 slides, in my presentation that. Again, till now, we are not there that the current polysomnography labs are able to give us this information. But as the algorithms are developing from the same polysomnography thing that we do, we will be able to kind of derive this, low threshold value or the loop gain from this data only. So, but still the logarithms need to come into, at a point which will be accessible to all of us. Still, we are not able to kind of, get into, to make it simplify enough. We have not been, but we'll be able to get it into the polysomnography data only.
So I think here we must emphasize the polysomnographic parameters in these cases. As we discussed today, insomnia, predominant OSA are very difficult to treat. They are poor tolerant to CPAP. So most of the categories of the patient, other than the PALM-1 class, they have a low arousal threshold and so poor CPAP tolerance. So in these cases, we can search about how the low arousal threshold can be diagnosed with the polysomnography. And there is clear-cut indications in these cases. 3 parameters has to be noted. AHI, if it is less than 30, that is mild to moderate. And if the patient has a hypopnea predominant AHI, that is hypopnea to apnea ratio more than 58, and they have a noddy SpO2 more than 82, that is less hypoxia. If the patient has less hypoxia, desaturation, if the patient has predominant hypoapnea and AHI is less than 30, 2 out of these factors has a sensitivity of about 80% and specificity 88%. Most of the patient can be diagnosed with this parameter that they have low arousal threshold. Similarly, just the opposite. If the patient has a high AHI, more than 40, and severe desaturation of the oxygen, and they have predominant apneic pattern, more than 90% are apnea. So this feature goes for the PALM scale 1, that is increased collapsibility like that. Similarly, if the polysomnography shows obstructive apneas along with the chain strokes respiration pattern, and that gives an indication for the presence of high loop gains. So these are the certain important polysomnographic features by which we can have an assessment about whether the patient has a lower arousal threshold or high loop gain or high peak rate.
Yeah.
There are particular.
इसमें मेहनत लगेगी अभी.
We can do a practice of searching these findings.
So I was saying, yeah, it's like you have to work on it yourself. And now when, otherwise they will, as we progress, they will give us like, as we get the snore index or the desaturation index, that will come in the logarithm itself. But yes, with this, we can, derive this.
Yeah. There is a question regarding AVAP's comparison to CPAP. So anybody would like to take that, or because AVAPs has no additional superiority over CPAP, and except in certain condition, if you want to ensure that, like in OHS, in certain advanced, and even in OHS, CPAP is the first treatment of choice. But if the patient is not maintaining, like symptoms are not improving, then only AVAPs, because these are advanced modes have not, they're very costly, and they hardly show any benefit. I would not recommend this they are not common garden type of treatments to be offered to.
Actually, only. Now, there is no need for AVAPs. AVAPs is volume assisted pressure support. Basically, it will assure you how much of tidal volume has to be delivered to the patient. But that has no role with what we are discussing, obstructive sleep apnea. Because
there is a question in the chat box. That's why I was trying to take all the questions.
So I think I'll just for the again, again the audience and the PGs, like, this is again a hierarchy, of the treatment. So this is a spectrum of the treatment. So we start with the CPAP. Then some patient may need, we may have to go up to the BiPAP, and even above, we may have to go to AVAPs. So it's not that directly we can offer AVAPs to any patient. So it's again part of the titration. Some patients may end up actually, needing AVAPs because, again, it's an OSA with an OHS. So these patients may still benefit again, but it's again, how you titrate again, it has to be like, through the spectrum. It is from the base to the upscale. So it's upscale, like you just move, so it's like,
There is another question like macroglossia. Yes, macroglossia especially, it's a very important, I have told you that in acromegaly, there is macroglossia, and a lot of patients have macroglossia by itself can cause OSA.
Even hypothyroid, most of the patients with hypothyroid, those who are poorly diagnosed very late, they have a bulky tongue usually. They may not fit the macroglossia, they have a bulky tongue. So these group of patients, if they have a problem with the tongue base and all, they may benefit with tongue-based surgeries and all.
Yeah, definitely. And hypoglossal nerve stimulation is basically that approach, but that's not available in India.
Yeah, there is still like, it's an invasive one, and it's again the cost effectiveness is not there still. So I think we are having very interesting, and nobody wants to go at this point, but yeah, so time is like running, it's ticking away. So I'll thank Dr. Zia and all my esteemed panelists for being here for this wonderful discussion. It was lovely interacting with you and with the audience, and thank you for these questions. We really enjoyed it. And yes, Khushbu, we will, have more of these sessions, more on sleep.
Yes, ma'am.
And looking at your interest, and we are all kind of encompass everyone in this thing. And thank you so much once again. Thank you.
Thank you, ma'am.
Thank you.
Thank you for having me.
Okay, ma'am. Thank you very much.